But I am going to, at the end, I'm going to talk about allergic rhinitis specifically and oral candidiasis, since we really haven't talked much about the antifungals. And I want you to know, usually when I teach allergic rhinitis, I teach it with asthma. I look at the respiratory tree as one continuous circuit. Because if you don't have allergic rhinitis controlled, your asthma won't be controlled. So they'll go together. But for this disease, for this organ system approach, they felt it was better to leave it with the nose. So that is fine. We'll just be redundant when we get into asthma as well. Or you'll already know that part. Okay, so let's talk about steroids. Sometimes I feel like things are so common that even among the lay public, these things are known. But I feel like I may shortchange you and assume that you know these things when you don't. And sometimes your questions reveal that I'm taking things for granted that I probably shouldn't. So corticosteroids are produced by the adrenal cortex. You produce glucocorticoids and mineralocorticoids. And they take care of things all over the body. So when we are making drugs that we call glucocorticoids, or people will use steroids, corticosteroids, glucocorticoids as one term. Okay. So when I'm saying steroids to you, I'm usually talking about glucocorticoids. When the lay public hears steroids, they often think anabolic steroids because that's what's in the news. So you have to be careful when you're talking to your patients when you're talking about steroids, because they may be thinking about something totally different from you. But those three terms are used interchangeably. So systemic steroids are great. They are one of the most potent anti-inflammatories we have. If you've got an inflammation, you want to have a steroid available. They're very good. Topically, orally, IV. Very good. The problem with them is that they cause very serious side effects if you have to use them for a long period of time. So we don't use them long periods if we don't have to. There are some diseases, especially immunologic, some autoimmune diseases where you have to use them. And so we try to get down to the lowest dose we can, and we try to do what we can to prevent some of these effects. So the steroids are hard on the bone. They help to resorb bone, and so osteoporosis and osteoporotic fractures are pretty common in people who have been on steroids for a long period of time. It also thins skin, making bruising and injury to the skin much more susceptible. Bruising becomes more common. We talked about last week cataracts and intraocular pressure increase. So glaucoma more common. The ability to recover from an infection. Anything you're suppressing the immune system, so its ability to respond will be limited. So if you're going to use them, when we get to RA and we're talking about it, we're using other immunologics, those folks get really high risk for big infections, tuberculosis, fungal infections. So when a lot of the diseases we talk about today, conditions, have a big inflammatory component to them. So being able to use a steroid is advantageous, but to use systemic steroids or oral steroids is just impossible because the risk will outweigh the benefit. So, and you see this over time, that the more we can target the organ we want with a drug, the better off people are. So intranasal glucocorticoids came about because of that, the need to deliver it specifically to the nasal passage and have the effect there and nowhere else. And so for the most part, it's been accomplished. These drugs that when they are, they have I'm going to skip that just a minute because I'm going to show you another picture, but they have much better safety profiles. You can use intranasal steroids all the time and have very little steroid effect. Even though you will get some, it still is low. These are the examples. Remember I told you to kind of look at these endings. So this lide or ide will tend to be a steroid. Also these older endings are also common with the steroids. Prednisone, methylprednisolone, those things, cortisone. Okay, so just to show you and impress on you that these drugs are not totally safe, because you do get some, when you know, we learned with the eye, you put it in there, you lose 90% of it, because it either goes out down their face, or it gets absorbed down the tear ducts and into the nose, and then it gets absorbed. Well, with intranasal steroids, the same thing can happen, is that they'll swallow about 70% of the dose. These drugs have high first pass effects, so what's that tell you when I say that? They go to the liver, and what's the liver do to them? Gets rid of them. So a lot of what they absorb will be metabolized before it can ever exert an effect systemically. But some of it will reach the systemic circulation, so there is the ability to have some adrenal suppression. The newer agents have less of that ability than older agents. So an old steroid that we used intranasally was called beclomethasone. It had a high, it did not have a high first pass rate and got absorbed a lot. So it tended to cause more trouble. So we don't tend to use that one as much. So that while our bioavailability here, we used our advantage. Most of it is not going to hurt the body, and we're not going to get much, if any, systemic effect. Okay, so inflammatory processes. When you are looking at drugs that hit inflammation, you have to think about the two phases. You have an acute phase that happens, and you have a phase that happens about 6 to 12 hours down the road. So some drugs are very good at taking care of first phase, and some are second phase. So first phase happens almost within minutes. You get a bee sting, you have an allergic reaction, that's that acute phase. So you've got IgE is the big immunoglobulin here who's interacting with the allergen. They bind together, they sit on mast cells, and then they degranulate. You have all of those pro-inflammatory cytokines that are released, histamine being one of them. So you need drugs that can stabilize that mast cell, that's long-term, that also can blunt the effects or block the effects of those pro-inflammatory. So antihistamines are one of those that can block that acute phase. All those cytokines, one of their jobs is they recruit. So inflammation always recruits cells to the area. It's like the triage takes care of it first, and then we call in the big guns. So the basophils, the eosinophils, white blood cells. They come in and they do other work, but they also are part of the inflammatory response because they also release pro-inflammatory cytokines. So when we use the word cytokine, what does that mean to you? Is that a term you're familiar with?
Cytokine storm.
So, an immune mediator, like it draws cells.
Okay, cytokines are like intracellular communicators. It's the way cells talk to each other, is they use these small molecules to send messages. So they're like an intracellular messaging, or not, it's intercellular, in between cells. So steroids work on the late phase, okay? They shut down that recruiting. They have to get into, if you remember from the very first discussion we had about receptors, these drugs have to get into the cell. They interact with an intracellular receptor, they're lipophilic, so they just move right through the cell membrane. There's an intracellular receptor there, binds to, and they move into the nucleus of the cell, and they change transcription so that they are either blocking what the cell is going to produce, or they are creating a new cell through messenger RNA in the ribosomes to block inflammatory response. So it takes some time to do that. So that's why when you're getting into a situation where you need immediate, you start steroids right away, but they aren't going to get you what you want for several hours down the road. That's why you have to use other things more immediately. Okay, so let's back up to the intranasal glucocorticoids. So they can act pretty fast, even though I just told you they're fairly slow. patients can get response within a day or so. It will take several days to see full effect though. This says maximum of 3 to 4 days. You will find people will tend to want to use these PRN. For some very mild cases, that's probably okay. They're much better if you use them continuously. You get better, you don't get an attenuation, you don't get any kind of tolerance built up to them. They're very good, but they're best when used all the time. They usually are foundational to treatment of an inflammatory process. So if inflammation is the main problem in a condition, then these steroids are going to be your foundation pieces. So when we get to asthma, that will be the case. It's an inflammation of the airway that produces all of those symptoms. If we can get that inflammation under control, their symptoms will abate and will go away. And we can prevent exacerbations that are sometimes dangerous to the patient. So when are they indicated? Well, when we're talking about our allergic rhinitis, which is one of the biggest inflammation pieces you had today, these are the preferred agents when you're talking about persistent, moderate to severe effects. Okay. So what you can expect if you prescribe these to a patient, or they come in and they tell you, because they can buy these over the counter now, what you should expect is they report they don't sneeze as much, their nose doesn't run as much, and their congestion will go down. So that's what you expect to happen. And you should tell them, here's what you will get out of this is when you use this drug. Okay, so we talked about a few hours to up to a few weeks. When we use steroids, it's kind of the backwards that you'll see us approach with a lot of diseases. Usually we'll start low with a low dose and we will titrate up. With steroids, we often start at the maximum dose and titrate down because we're trying to get the inflammation under control, and once it's under control, then we'll back it down to the least amount that would control symptoms. You won't see that very often, but this is one of the times where we will do a downward titration instead of an upward titration. These products come, mostly they're suspensions. And some of them are solutions, but they're mostly suspensions. There are some dry powder formulations. These drugs tend to be somewhat a little bit annoying when you inhale them. They can sting. Kids don't like them as much. For people who really can't tolerate or won't tolerate, there are these dry powder formulations which are just less irritating to the nose. So I threw those in there. They're more expensive. So these would probably not be the first go-tos. These would be things you might use if you have got to have that effect and the patient won't use others that are on the market. Because there are ones over the counter, I can tell you that your insurance companies are going to probably drive it that way because they won't pay for over-the-counter products. They won't, so it'll be the patient's cost. But so they'll force you that way. So these drugs, if you put them on first, you'll get little notes from the insurance company saying, we're not going to cover this because you haven't tried these other things first, or you have to tell us that you've tried them before you can use them. Wanted to show you in terms of using these agents, just a couple of things. One is the shaking because they are a suspension. Asking patients to blow their nose before or instructing them to. The other is if they're going to use saline, nasal saline irrigation, do that first. It helps to, if they're doing it, it helps to clear out any junk, debris, mucus, and it gives a cleaner surface for the drug to work. You don't have to do it before, but you certainly don't want to do this first and then do the saline wash. In terms of aim, it's important because if they continually spray steroids at the septum, you can get, I don't know if you can get perforations, but then they tell you The other you will see, especially in the winter months, is that you can get it nosebleeds. So if you get a nosebleed with someone who's on a held steroid, you would hold that. So that's the one thing you want people to aim it away. Okay. Adverse effects, these are usually really well tolerated. Stinging, burning, that is momentary, irritation. Headache, pharyngitis, if they swallow it and they get a lot of local effect in the pharynx, they can do that. You talked about nosebleeds, cough. Almost any drug can cause nausea and vomiting, almost any. But again, if they swallow it, it may upset their stomach, especially in kids. You can see adrenal suppression of their of these glucocorticoids on the adrenal axis with long-term use. Okay, so where you will see it in today's treatment is the allergic rhinitis. It's first line for moderate to severe. It's an adjunct in adults with the chronic rhinosinusitis, whether they have nasal polyps or not. So with the nasal polyps, it can, did you all talk about today, they can help shrink down and they can also help restore some of the loss of smell with those folks. And it can be used as an adjunct therapy in bacterial sinusitis just to get the inflammation down. Okay, questions about the intranasal steroids? Anything I said just this morning or today that you contradicted what you heard this morning? Okay, good. Okay, let's talk just a little bit about oral glucocorticoids. So with oral glucocorticoids, the big problem that we run into is that they're great, they do their job, but there is all this negative feedback up on the brain that controls the release of ACTH, which directs the adrenal glands to produce steroids. So when you suppress that axis, meaning you shut down, if you're putting out a lot of glucocorticoids, you're taking them orally, then you've got a lot of negative feedback all on this axis. If you stop it abruptly, then the axis will pick back up, but it cannot do it immediately. So the problem with that is that if the person gets into a stress reaction, they are in a car wreck, they have a major illness, a major trauma of some kind, they can have what they call an adrenal crisis, and that can be life-threatening. You can die from that because you can't put out the cortisol. Cortisol is one of those stress hormones that is needed during times of great stress to the body. So it's very important that we taper. We can use drugs for the steroids for a short period of time and not taper, usually up to about 5 days, but after that we need to taper. Did you all talk about tapers this morning or adrenal crisis? Did you talk about adrenal suppression? Okay. So that's why we do steroid tapers, is to allow the adrenal gland to recover so that by the time we stop it, if we're using it for 7, 10 to 14 days, the adrenal glands, it won't be perfect, but they'll be able to put out enough to keep the person out of trouble. Okay, so this is what people refer to as a Medrol dose pack, and it is packaged in a way for an easy taper. So if you've got somebody who's got poison ivy, this is an easy way to dispense a steroid taper. Okay. Usually we'll have the folks take the drug in the morning with food because it can upset stomach. And it also has the least impact on cortisol, about 5 to 9, 5 o'clock in the morning, 9 o'clock in the morning. Most cortisol is put out, so this has the least blunting effect on their own cortisol production. Okay, I know I covered that last time, Friday, but I had some questions, so I thought, well, maybe I should just review that again. Okay, so in the diseases today, where this comes up is in chronic rhinosinusitis with nasal polyps and with or without, that was the mainstay of treatment, was to get the inflammation under control. So at least in the references I looked at, anywhere from 10 to 15 days of an oral steroid. Sound familiar? And then the shrinking of the polyps and the improving sense of smell. Did you all talk about that today? Is that, I don't see, did you all not talk about that? You didn't talk about, did you talk about chronic rhinosinusitis? You did. Did they talk about, did they differentiate between polyps and without?
Yeah.
Okay. But they didn't talk about using glucocorticoids?
She
Yeah.
said it used for polyps.
I thought it was a nasal spray.
I thought it was nasal spray.
spray.
Nasoport, right?
She said
I
after.
think it's fine.
Really?
Nasal spray, Advair.
Well, Advair is a mix of beta agonist and a steroid.
She used some nasal spray.
Okay, so in an acute, the recommendation is oral steroid. The maintenance with those is a spray. But the amount of prednisone they recommend is like 60 milligrams for 5 days. It's in your handout. And then tapering it over another 5 to 7 days. Who taught this morning? And I'll just make sure we're not crossing. Oh, okay. Okay, so that's all I want to say about steroids. Antihistamines, I'm going to move to the... Let me go back over first and second generation, because I throw those terms out, and I want you to know what we're talking about when we were talking about first and second. So remember, we talked about when we're talking about generations of drugs, it's usually when there's a huge change. The drug still works the same, but you're making some major change to it, either different, you're getting away from a side effect or you're broadening coverage, like with the antibiotics. So with the old first generations antihistamines, that's like Benadryl. That would be the most common one that everybody would know. They are great at interacting with the H1 histamine receptor. The problem is that they interact with a lot of other biologic receptors in the body, so they cause lots of side effects, and they cross the blood-brain barrier. And when they do that, they interfere with histamine, which is one of the neurotransmitters in the brain. And that's why it makes you go to sleep. So we can use that side effect to our advantage. But one thing when we talk about older folks, it is now being recognized that the use of anticholinergics or drugs, using a lot of drugs that have anticholinergic effects, and you see this in the elderly, lots of their drugs will have anticholinergic effects, that it is either thought to lead to dementia or it is worsening dementia. So we really want to stay away from drugs that have a lot of anticholinergic effect in the elderly. So antihistamines have anticholinergic effects. So that's, I reminded you there by putting up the SLUD is cholinergic effect, anti-SLUD is anticholinergic effect. So we prefer the second generation's antihistamines, and I gave you, those are just some of them, there's 8 or 10 of them out on the market. These do not cross the blood-brain barrier. They're also much more specific for the H1 histamine receptor. So we don't get as many other effects from the use of these that we do with the first generation. And they have very limited, or in some people, no anticholinergic effects. So this is just a diagram to show you the mechanism of action. It's one of those G protein coupled receptors that we talked about in the very first day. And they are going to lead to a decrease in the expression of pro-inflammatory cytokines. And they're going to block histamine's ability to sit on that receptor and cause an effect. They also, it's recognized that a lot of these antihistamines also have some mast cell stabilizing effects. And so we can use that to our advantage as well. But the antihistamine part is going to be the one that that's going to work on those early phase of the inflammation, and then we get some late phase through the mast cell stabilizing effect. So antihistamines, when people tell me they have a cold or they don't, they want to self-medicate, you always want to ask them, what is the symptom? What are you after? Okay? So antihistamines are going to be drying agents. So watery eyes, runny nose, anything where there's an increase in secretions, that's what antihistamines will take care of. They will not help congestion. If they have a cough due to the postnasal drip, it'll help the cough just because it's taking care of the sinus drainage. Okay? So drying, anything that you want to do. So targeting symptoms is much better than just doing shotgun approach with a lot of different agents after a lot of different symptoms. Usually the effect is pretty fast. They are not as good as the intranasal steroids, but they are very good add-ons. We'll see that when we look at allergic rhinitis, they are very good for just intermittent here and there. You know that you're going to come in contact with something that triggers, or you encounter a trigger. These drugs are pretty good at giving you quick relief. So faster onset, but not quite as good in maintenance. Adverse effects, again, it's usually a drying mouth, sometimes sleepiness, sometimes headache. And the nasal agents, anytime you're putting something in the nose, it's usually the stinging, the burning, irritation. Azolastine, which is commonly used, has a real bitter taste to it. So that one, you have to either warn patients or get them to rinse and spit after they use it. Okay, so where these came up in the diseases that you had today was in the mild intermittent allergic rhinitis, or in the moderate to severe as an add-on to the intranasal glucocorticoids, and then also as an adjunct with the chronic rhinosinusitis was listed, whether they had polyps or not. Okay, any questions about the antihistamines? Is this helping? Is it redundant? Or is it helpful or not? Okay.
Would you want to get that, like, because I take both, like I take like an oral antihistamine and I do the nasal spray, because I have seasonal allergies. Are you supposed to do both?
You can.
You can, and
Yeah.
it's not like.
If it's helping, if you're getting breakthrough with an intranasal glucocorticoid, or you don't get full symptom relief, then it's very reasonable.
Okay.
If somebody put you on that in the beginning, then it's reasonable also to back off and see if you can get by with just a steroid. You can do it while you can't hurt. You'll know pretty quickly whether or not it worked. Okay, decongestants, pretty limited use, yeah.
Sorry, for all, for the antihistamines that she just went over, are you including just general antihistamines, or those that also include the mast cell stabilizing properties? Are those included in all this as well? Does that make sense?
Most of those, I think in last week, I gave you the list of those that had mast stabilizing effects. And that's a lot of those intranasal steroids have those. The oral ones, I haven't read anything that says that they have them, and I could be wrong on those. But most of them, you're looking at those intranasal. So decongestants, great drugs, but also great potential for abuse. So in Oklahoma, it's hard to get a hold of pseudoephedrine anymore because it is one of the basic ingredients to make meth. So it's very limited in terms of its ability. So we don't have a lot of great decongestants over the counter anymore, except in like the nasal sprays, like in Afrin would be probably the most common, or its generics. A couple of places we do use them though, they are very important. So these are going to be congestion. So if somebody is really congested and they are not getting the effect from an intranasal steroid, this is the drug to use, because it's a vasoconstrictor. It'll constrict those those little blood vessels, and so you won't get as much blood flow through, you don't get as much edema, and so they'll get relief. The problem is that because you're dealing with the sympathetic nervous system, it will down-regulate its receptors, or it will find another way to get around where you are targeting, and so they'll get a rebound of nasal congestion. So this is a real problem. We refer to it as rhinitis medicamentosa. That's why it's recommended you not use those products more than about 3 days is most conservative. A week would be the most liberal. Now, if you've got somebody on steroids and they're using these, the steroids will usually help with that regulation, and that's what that down regulation. We also use it to treat rhinitis medicamentosa, is with a nasal steroid. Okay. So remember, these are alpha-1 adrenergic blockers. So they're blocking the postsynaptic response to norepinephrine. So like we did with the eyeball, if we want to decrease the redness and congestion in the eyeball, we use an ophthalmic decongestant. Same with the nasal decongestants. Biggest problem is it's just not using them long term. So the other place we can use them is a nosebleed. So we can constrict those vessels and get the bleeding to go down. So we can either spray it into the nose when they've got a nosebleed, or we can impregnate those cotton packing or the cotton plugs that they use, or the cotton tampons that they use. So you don't get a lot of reaction, you don't get a lot of side effects with the nasal sympathomimetics, except for the rebound. They don't get absorbed as much. If they did, you would get more of the cardiovascular effects. So it would be increase in heart rate would be probably the main thing. Okay, cromolyn. I put cromolyn in here because it is not it's a very effective drug. It's just weaker than compared to some of the others that we have. The other is that it's safe. It's very safe. So a lot of pediatricians will prefer it in children and in pregnancy because it doesn't have the long-term effects that we'll see with the steroids. So cromolyn is a mast cell stabilizer. Very, very good. If you have people who have seasonal, let's say they have intermittent seasonal allergies, starting this about a week ahead of time will help a lot. You will also run into people who will not use steroids. You'll run into parents who will not want you to give their children steroids because they will have heard bad things about them. There is information out there in the lay press about it suppressing growth, and it does. It does suppress growth rate or velocity. Children usually attain their full height, but they do it at a much slower rate. So there is some of that concern. Usually by educating the patients and looking at risk-benefit, you can get most parents on board. Where I found a lot of pushback was when I was taking care of adolescents with asthma. And it was the boys who really pushed back. They felt like it made them weaker in sports and with weightlifting. And so it was very hard for me to get young teenage boys to adhere to inhaled steroids for their asthma. So this is an alternative. It's just not as strong. It also requires more frequent dosing. Intranasal steroids we can get away with once a day. With this, it's best at 4 times a day. Some people can get by with 2 times a day. So remember, with those great mast stabilizing effects, very, very safe, has to be started ahead of time, at least a week ahead of time. And if you start it, it takes several weeks to see its peak effect.
So you want to use this like
Never acute.
in entire season, like half
You
the
could.
season?
You could very well. They'd probably get better effect if you did it all season. You could use it all year round. It's not going to harm.
So this isn't a steroid, or is
It is not a steroid, not a steroid at all.
So, in the eye lectures, you brought up Cromolyn drops for allergic conjunctivitis for pregnant. That's our first line. What about the vasoconstrictor? Why would we not want to give them Nafpane? Or in this case, why are we giving them Cromolyn? What is the significance of the vasoconstrictor in a steroid?
What is the, say it again?
So with
Frame your
pregnant women,
question.
why are we wanting to not give them a steroid? Is it the vasoconstrictor that's causing the issue? What are we looking at?
So some people may not choose to do it. Some pediatricians may not want to, in mild disease, to use a steroid with a child. Just because of its long-term effects, you've got a growing individual, so you don't want those long-term steroid effects, unless it becomes where benefit greatly outweighs the risk to the child. So this is a safe alternative in mild situations. And in pregnancy, you can't use the vasoconstrictors long-term in a pregnant woman, and you don't want to do it in a child either. So those are the reasons why this would be like a third line go-to. Does that?
Yeah, I was just curious why in pregnant women the vasoconstrictor, what it would cause issues with.
Well, some of it is, when you're getting to term, it can precipitate labor. It can also, you're wanting a great blood supply to that growing fetus, so you don't want to interfere with that as well. You don't want the blood pressure to go up, especially if you're dealing with an eclamptic situation or preeclampsia. So many reasons. Does that
Yes.
help?
Yes.
Okay.
That's fine.
Okay, so this is just, I think I gave you this when we were talking about the eye, so it's just that stabilizing mast cells, so they won't degranulate. Not a quick onset, so that's one thing to keep in mind. And about the only place we're gonna see it is in this group is with the allergic rhinitis. We'll see it again in asthma. Okay, so montelukast is a leukotriene receptor antagonist. Yes?
I'm sorry, I have one more question on the steroids. I've heard patients refuse steroids because of weight gain.
Yes.
Isn't that mainly water weight, or is it
It is.
so you can reassure them that they're
it-
gonna?
Well, it is and it's not. If you take steroids for a few days, it revs up you want to eat a lot. So some of it is increase in appetite. The others, if you take them long-term, steroids will tend to redirect where you deposit fat. So that's where that moon faces, buffalo hump come from, is because steroids redirect where fat is deposited. So with the nasal steroids, we're not going to see that. But that's why they might refuse oral for very long.
Okay.
Okay, so montelukast, singular is the trade name for this one. So leukotrienes, again, one of those pro-inflammatory cytokines. And so this drug blocks its ability to exert an effect. So it's just blocking one of the other inflammatory products and blocking to produce an anti-inflammatory response. The thing is that, again, they're not very strong. They're not as potent as what we'll see when we use a steroid. But they are sometimes add-ons. If you've got somebody who can't tolerate one of the first or second line drugs, this is one you can add on. Or if you're getting breakthrough symptoms, or if you can't get a complete response, these are ones to add on. They're fairly expensive. I put montelukast up here because there are 3 of them that are in this category, but this one is probably one of the safer ones and has indications down into children, in young children. Lots of different dosage forms. So this one, the cystidyl leukotrienes are the ones that are involved in inflammation. And here's the things they do. Edema, so you get congestion. They draw inflammatory cells. They lead to contraction of smooth muscles. They also disrupt the epithelium. So they're fairly destructive products in inflammation. So that's one of the reasons they've been a target for drug makers. Dosage forms, there's a lot of them. They have granules for kids that you can, or for very young kids that you can pour into applesauce or yogurt. They have a chew tab for for older children, and then they have tablets for adults. So they're very, very accommodating and very easy to use. The major thing with them is a flu-like syndrome that can be fairly long-term. Is probably the biggest thing you see with that one. Very well tolerated otherwise. So again, it's going to be an add-on, and it won't be what you will see. When they first came out, a lot of physicians went to using them instead of an inhaled steroid. They're just not as good, not as potent. But in mild disease, they can help. In disease where you can't get everything you want out of the first and second line drugs, these are ones to consider. They were also, if you've got a lot of eosinophilia in an area, these might be a good agent to consider. So they were listed as adjunct therapy in the maintenance of chronic renal sinusitis without polyps. And also when polyps are present, so either one of those. Okay. Ipratropium, so we keep working our way down the road. So we're now in the area where these are not very commonly used in the diseases you looked at today. But ipratropium is an anticholinergic. We'll see it used a lot when we get to COPD. Because in COPD, the parasympathetics are the main controllers of the airway, so they become very useful there. In allergic rhinitis, they have limited use, but if you've got somebody who has just prolific rhinorrhea that you cannot control any other way, this is a good drug. It's targeted, it'll dry them up. So not recommended as first line. You could use it as second line if you've got or third line. If you've got the intranasal steroid on board and you can't tolerate an antihistamine or the side effects are causing trouble that the patient doesn't want to tolerate, you could look at ipratropium. It comes as it's an antimuscarinic agent. Comes in little pump sprays. Again, dryness, nosebleeds, nasal irritation. It's going to be local effects or local side effects. Any questions about that one?
Is this one that you're using older people? Because the
You can, yeah.
does it have the anti-cholinergic?
Yeah, it does. It does. A lot, but with this one, it's mostly local. And it is not a great one to get absorbed. It's a big quaternary amine or ammonium. It just doesn't cross the cell barriers very well. Nasal saline. Did you all talk about saline sprays and saline irrigations today? Briefly, okay. Did you have a question on
Yeah, sorry, on that last one.
problem.
As far as choosing Montelukast versus ipratropium, is it just based on rhinorrhea being the primary symptom?
So once you get past the intranasal steroids, and when you're looking at any kind of sinusitis, it's then what is the symptom I'm dealing with? What is not being controlled? What are they complaining about? Then you target with those agents. And histamines are going to be probably one of your big ones to go to. These other than come in when you can't get a complete response or they're not tolerating usually your second line, because most people can tolerate their steroids. And they're going to get good effects from it, so they should be more motivated to use it. Okay, I want to say some things about here because of the bad side of them, as well as the good side. So nasal saline, you can buy saline over the counter that's in nasal spray. It's isotonic. so it doesn't tend to be very irritating, it can be very soothing if people have a lot of dry nose, it can be very soothing just from that. For mild congestion, it can be pretty good. That salt can help break up the mucus, make it less viscous, and then you can blow your nose and get rid of a lot of it. So it's a really good kind of nasal hygiene approach. They're fairly inexpensive. Ocean Spray is a common one. They've got a lot of new ones that are more foamy, like Simply Saline. Those are gonna be more expensive. You can get generic for $1 or $2. The biggest thing is just making sure they, use good hygiene. Washing their hands, keeping the bottle, keeping the junk that they get on their nose off the bottle. That would be great. They're over the counter. They clean out debris. They can be used often, so they're kind of like dry eye drops. You can use them frequently. Now, when you go to saline irrigation, the best place I have found for the recipe for the saline is I gave you the link for. I went back and made sure that link was still valid. So that's probably one of the best ones. Here's the problem with nasal saline. If people do not do it right, or they don't keep the pots clean, they can get infected and they can reinfect their sinus passages. And if they use tap water that contains, did y'all talk about the amoeba? No, okay. So I'll do that. So these are fairly easy to use. You follow the recipe, you keep those pots clean, and you can irrigate your nasal passages several times a day if you would want to, but as frequently as needed. So in a lot of these, like the sinusitis, the chronic sinusitis, this is a good adjunct. And again, doing it before they use a pharmacologically active product is the right way to do it, the right order. You can buy neti pots. There's a brand called Neti Pot. Here's the bad side, is that there is an amoeba, and I don't know that I can even tell it to you. It's contaminated water, contaminated tap water. There have been deaths from this, and they've been recent. They were in the news a couple of years ago. So it's devices that become contaminated with this, and the patients use them over and over again. So good hygiene, knowing how to use these is really important. So that's why. So they recommend using distilled water or boiled water. Okay, so we talked about those for sinusitis. Okay. Why don't we take a short break and then we'll come back and finish up we've covered the majority of it.